Hello, everyone. Our session today is going to be focusing on nutrition and hydration in serious illness. My name is Cynthia Pan. I'm the Chief of Geriatrics and Palliative Care at New York Presbyterian Queens. We have a panel of speakers on our workshop. Dr. Krupi, you want to introduce yourself?
Hi, Dr. Robert Krupi, and Director of Palliative Care Services in New York Presby Queens.
Okay. And Kathleen?
Kathleen Adenolfi, Speech Pathology Supervisor in New York Presbyterian Queens.
Great, thank you. So we're excited to be here to be talking with you about this great topic, a lot of prevailing issues. We don't have any financial conflicts of interest to disclose. Our objectives today are to compare and contrast the role of food and nutrition in healthy states versus serious illness because they're not one and the same. We want to discuss the role of appetite stimulants in serious illness and clarify utilization. We want to review advanced dementia as a model for serious illness where artificial nutrition and hydration issues abound, and also analyze the risks and benefits of PEGs or feeding tubes in dementia as well as other illnesses, and share some useful guidelines with you. And then speak with you about an innovative policy-driven approach to implementing high-value care at New York Presbyterian Queens, and discuss decisions about feeding options in advanced dementia. And then finishing up with the integral role of speech-language pathologists in collaboration with palliative care and geriatrics. So beginning with the importance of food. Food is so essential, always at the center of gatherings to share major life events, whether we're well or we're sick. With the sharing of food and drink, we celebrate and mark significant milestones in our lives, starting with births and weddings and graduations, also wakes and sitting Shiva and everything. I remember when I got married, my brother doesn't remember too much about it, but he did remember the lamb chops. So food is so important in all of our lives. Food and drink are also highly symbolic. Think about Thanksgiving turkey, Passover matzah bread, Easter lamb, Lunar New Year dumplings, etc. So to give food and water really demonstrates nurturing, care, and concern. It's really a way of showing love. And that's why food at the end of life or in serious illness can become a big issue sometimes. So also just to set the background about using food in healthy situations and populations is that food is usually seen as sustenance and facilitating life processes. Eating well is associated with being healthy. Losing weight unintentionally is normally a bad thing, a bad sign. And starvation is seen as cruel. And healthy people often find it uncomfortable to be hungry. People become hangry and things like that. So that's what happens in healthy people. However, these principles don't really apply to patients who had advanced or end-stage diseases. The typical goal for regular healthy patients is these things. We're not going to name all of them. You can see it on the slide. But these goals are not necessarily realistic in patients who have advanced or end-stage diseases. As a matter of fact, anorexia and cachexia are expected symptoms in the illness trajectory. So in addition to anorexia and cachexia, dysphagia and swallowing difficulties are also common and very ubiquitous symptoms for seriously ill patients, especially at the end of life. All roads kind of lead to dysphagia, swallowing difficulties, anorexia, cachexia, when people are at the end of life. As a matter of fact, in South Australia, they created guidelines for diet and nutrition and palliative care, focusing on things that are more related to people who have serious illnesses, including what does palliative care nutrition look like, optimizing nutrition in the setting of serious illness, providing ideas for nourishing drinks and nutritional supplements, tips to improve eating and nutrition even when the appetite is poor, sample meal plans, dealing with common symptoms in the setting of nutritional needs, and then talking a little bit about tube feeding and nutritional support also. So I think it would be great if in the US we can also provide or develop a set of guidelines about nutrition and diet and palliative care. So some of the information that they provide is dealing with common symptoms such as dry mouth, taste change, swallowing problems, nausea and vomiting. They have a lot more, so I definitely encourage you to go to this guideline resource. And how do you frame these symptoms or treat these symptoms in the setting of diet and nutrition? And they also do talk about the integral role of speech language pathology. So we're very happy to have Kathleen here with us today. So one thing to really remember is that there is a set of differential diagnoses when it comes to people with serious illnesses or advanced dementia, for example, who then have poor PO intake or dysphagia and weight loss. Not to just assume that it's end-stage illness. Of course, that's part of it, but there are also potentially reversible things that could be going on, such as constipation and GI motility issues and GERD and fecal impaction. Many times these patients become more bedbound or chairbound and are at high risk for constipation and do not have a bowel regimen. Depression is something that's also highly prevalent in serious illness and at the end of life, and some of the patients can be very responsive to treatment. Fatigue and decreased physical activity and functional loss, leading to less need for caloric intake. Pain is another potentially reversible cause, early satiety and nausea. Medication side effects, very important to think about deprescribing at this point. Xerostomia, dry mouth, as well as oral thrush, very prevalent, especially for patients who are immunosuppressed, having antibiotics or chemotherapy, for example, as well as poor dentition and ill-fitting dentures, common in cachexia, common in the elderly population, as well as differences in food. In our very diverse cultural societies, maybe the foods that we're offering in the hospital or in the nursing home are not the preferred foods for that particular culture, and therefore patients don't want to eat. And then social isolation, just the process of having food preparation and feeding assistance, maybe a little music and company. So I'll pass this over to Dr. Krupe.
Okay, thank you. So I'm going to be talking about appetite stimulants, and I'll preface it by saying overall, appetite stimulants have not been demonstrated to improve long-term survival and may cause serious adverse effects. Magos, progesterone, and mirtazapine are probably the first two things, drugs that come to mind when we think about appetite stimulants. But let's start with Magos, progesterone. It may actually result in weight gain, but that weight gain is primarily fat. There's a significant risk for DVT. The abuse criteria in AGS choosing wisely guidelines do not recommend it, and consider that many of these patients can, in fact, immobile or relatively immobile and have other risk factors for DVT. So there's a significant risk here regarding DVT. Bottom line, not really shown to improve anything quality of life. And does not improve survival. Mirtazapine, Remeron, is the brand name. Probably what we most commonly see used for appetite stimulation. It's an alpha-2 agonist, antidepressant, antagonizes the 5-HT3 receptor. Very limited evidence for it, but may benefit patients with concurrent depression. The thing is that it may not be better than other antidepressants for treating depression or appetite. Depression is the source of the reduction in one's appetite. Dosing, usual range of 7.5 to 30 milligrams early at bedtime. We always want to start low, particularly with geriatric patients. We recommend starting at 7.5 milligrams as a trial. One must exercise caution if a dose is greater than 30 milligrams, if there's hepatic renal insufficiency, because that may elevate the drug levels, and result in more adrenergic and serotonin effects, which may in fact counteract the appetite stimulation. Corticosteroids can provide energy. They're anti-inflammatory. Almost all the data is for patients with advanced malignancy. However, there are again significant potential adverse side effects like GI, fluid retention, worsening heart failure, hypertension, and CNS effects. Anabolic steroids, exandrolone is the only FDA-approved drug for treatment of cachexia. There is some evidence for improvement of non-healing ulcers for patients with weight loss, and improved appetite and weight gain in patients with COPD. But these studies are very, very limited, and there are no studies in nursing home population. This drug is contraindicated in prostate and breast cancer. One has to exercise caution with hepatic disease. There's actually, in fact, very little role probably for anabolic steroids, except for those patients who have hypogonadism, where they need supplementation. Appetite stimulants, regarding the marinol, duranabinol, I think we're familiar with this, but its use is primarily shown to show improvement of appetite in age. These aren't really it's not well studied in older adults. It can cause low blood pressure and significant CNS effects, particularly aldosterone, which really limits its use in older patients. Then there's cannabis and cannabinoids, CBD, for which is insufficient evidence. Okay, cannabis does pose significant risk of psychosis, anxiety, cardiovascular side effects, including MI and arrhythmias. Okay, and also the risk of postural hypertension, postural syncope. Cyproheptadine, an older drug, not so much used anymore, but again, okay, not effective, not recommended by peers. Criteria called choosing wisely, has significant anticholinergic side effects, can cause sedation, confusion, and does increase the risk of falls. Thalidomide has been looked at, okay, but there's insufficient evidence. So I'll end this by saying, given the lack of benefit and potential harm, okay, for using appetite stimulants, okay, I will end with this question. Okay, do you want to increase hunger in someone who may have difficulty eating or decrease tolerance to food? I'll hand this back to Cynthia.
Thank you. So first principle, do no harm. So now I want to talk about resetting nutritional goals and expectations in advanced illness, given that food is so important in all of our lives and cultures, that some of our newer goals for patients who have advanced illness, maybe that patients and caregivers will receive educational counseling around realistic risks and benefits of artificial nutrition and hydration, that the patient will tolerate a diet prescribed with minimal adverse side effects, is never going to be zero, that the patients will have adequate pain and symptom control to facilitate their desire to eat for their quality of life. Patients will derive pleasure from food and quality of life using pleasure feeding or comfort feeding. And later on, Kathleen will talk more about these concepts, and that the patient and the family will accept certain risks of aspiration while continuing oral feeding for pleasure and comfort. So these could be some more realistic goals in advanced illness, because in my experience, a lot of patients and their families really don't want a feeding tube. So given that our population is growing, we want to use advanced dementia as a model of serious illness where feeding issues are highly prevalent. A little bit about dementia facts and figures. According to the Alzheimer's Association, as of 2024, there's an estimated almost 7 million Americans aged 65 and older who are living with Alzheimer's, and 73% of those are 75 or older. About 1 in 9 people aged 65 and older has Alzheimer's. That's about 11% of that population. And about 2/3 of them are women. Compared to older white Americans, older Black Americans are about twice as likely to have Alzheimer's or another dementia. And then older Latinos or Hispanics are 1.5 times as likely. As everyone already knows, people who are older and get Alzheimer's or another type of dementia, mainly Alzheimer's, that there's a long survival time period, usually on the average of 4 to 8 years, longer than cancer, let's say. And some people can live out as long as 20 years with it from the time of diagnosis to the time of death. This reflects a slow, uncertain, and up and down progression of the disease, but it also offers an opportunity to discuss advanced directives and preferences. There is advanced lead time for that, and we need to encourage patients and families to do so. So when we talk about dementia and Alzheimer's, we want to use fast staging, not only for us to think about it, but also in terms of documentation, because when we say, oh, this patient has dementia, it doesn't really give us a sense of how advanced it is. So fast staging goes from 1 to 7. As you can see, 1 is no difficulty, either subjectively or objectively, 2 being normal older adult, 3 being early disease, 4 being mild disease, stage 5 being moderate Alzheimer's, stage 6 being moderately severe Alzheimer's, and then stage 7 really severe or end stage, losing the ability to speak intelligibly, not being able to have a conversation, more limited to yes, no, and single word answers, not being able to ambulate or sitting up without assistance, and then finally losing the ability to smile or hold their head up. So these are all signs of end-stage disease. Susan Mitchell and her group conducted this really good study. It's not completely new, but it's a really great reminder and worth dissemination. And it's about the natural course of dementia in the Cascade study. standing for choices, attitudes, and strategies for care of advanced dementia at the end of life. And it's a observational study perspective of over 300 nursing home residents with advanced dementia, followed over 18 months. And during that time period, 54% died, which means that they were all hospice eligible. The probability of death in 6 months was about close to a third. And during that study period, the probability of at least one episode of pneumonia was 41%. At least one episode of febrile episode was 52%, and an eating problem arising 85%. So looking at this, these are all common things that we expect to see with advanced dementia, especially in a nursing home population. So when you have an elderly patient with dementia, especially coming from a nursing home, coming in with dysphagia or aspiration pneumonia, we really should not be surprised. We should be normalizing to the family to say these are expected symptoms. This means that the disease is progressing. And aspiration pneumonia is the leading cause of death in end-stage dementia. The good news is that tube feeding in nursing homes in patients who have advanced dementia from 2000 to 2014 has been decreasing with a lot of education, choosing wisely, high-value care, which is really good news. And that is seen across racial groups as well, and remained relatively higher among Black residents, which is consistent with prior research. A more recent study that was published in 2024 looked at in long-term care, what are the resources to support decision-making regarding end-of-life nutrition care? This was a scoping review, and this group came up with 5 themes where in long-term care they need more resources to support decision-making, including conversations about care, what kind of care, using evidence-based decision-making, so things like choosing wisely guidelines, the need for multidisciplinary perspective. So like we're doing, including palliative care and geriatrics and speech pathology and diet and nutrition and others. Another theme is honoring the residents' goals of care. And the only way to know what the nursing home residents' goals of care are is to really ask them, right? Early enough before they lose their ability to speak and communicate. And then the last theme is cultural considerations for adapting resources. So this is another study looking at challenges around artificial nutrition and hydration near end of life for dementia patients. There are challenges around advanced care planning that they should include nutrition and hydration in the advanced care planning and what the patient's preferences are. Verbal communication is, of course, diminished in end-stage dementia. So really relying on nonverbal communication or facial expressions. A lot of dementia patients do pull out feeding tubes once they're placed. I personally have had a patient who pulled it out 5 times. And, so it was very tough for the attending physician as well as me as a palliative care consultant. Another challenge is helping patients to eat and hydrate while balancing the risk of choking and aspiration. That requires skill, and teaching is never going to be zero. So we want to just provide as safe as possible a setting and teaching the family skills, caregiver skills to provide that, but acknowledging that aspiration is always going to be a risk. And also the time, especially in nursing homes, as well as at-home caregivers. It takes a long time to feed patients who have dementia. It can be a struggle sometimes. There are aversive feeding behaviors. And there was a book that was written called The 36-Hour Day about caregivers and how they struggle with dementia patients. And then there's also limited understanding of the natural progression of dementia, not only with patients and families, but also with a lot of healthcare professionals. So we need to continue to do this kind of education with all groups. Another systematic review meta-analysis that was done and published in 2021 compared patients who have dementia, advanced dementia, with feeding tubes versus without feeding tubes, and actually found that patients who had feeding tubes had a higher mortality rate, a higher risk of pneumonia, and a higher risk of pressure ulcers. So, so we have to really do no harm in this population. The meta-analysis also found that female patients with advanced age were more likely to have increased mortality when receiving tube feeding, and that these patients also demonstrated a high refusal rate, either by pulling things out or resisting NG tubes, for example. So this is a good graphic of the outcomes of enteral tube feeding for patients with advanced dementia. Basically, all the things that we wanted feeding tubes to do, like improving survival, quality of life, and reducing pain, none of them have really panned out with the evidence that we have, and pressure sores actually increase. And that makes sense because once a feeding tube in place, there's a lot less incentive to get the patient out of bed and sitting in a eating position. It's much easier to just let the patient be in bed and elevate the head of bed and just start providing the feeding via the tube. There's also recent articles, and this is an example of one about ethical implications of nutrition therapy at the end of life. Some people do see providing artificial nutrition and hydration as an ethical issue rather than a medical issue. But I hope that with the evidence that I just presented, that the risks actually outweigh the benefits, that it is a medical issue much more so than an ethical issue. But nevertheless, this ethical implications article from the gastroenterology group talked about that a treatment should be offered if there's expectation of benefit, and clinicians are not obligated to offer non-beneficial treatments, such as feeding tubes for advanced dementia patients at the end of life. Of course, also taking into consideration the patient's values and preferences, and that's why early discussions are important. A discussion of all potential outcomes, prognosis, functional status, disease trajectory, and physicians shouldn't be afraid to make recommendations against the feeding tube and for comfort feeding. So in fact, that's what Choosing Wisely from the American Geriatric Society, the American Academy of Hospice and Palliative Medicine, as well as American Medical Directors Association, which is for post-acute care, all really recommend that percutaneous feeding tubes in patients with advanced dementia are not recommended. That instead we should be offering oral assisted feeding, comfort feeding, or pleasure feeding, whatever you want to call it. Here's a study that was done looking at who is more likely to recommend PEGs, because patients and families, they do want medical recommendations many times. So this is a study looking at that junior medical staff and nurses were more likely to recommend PEG feeding in advanced dementia patients compared to dietitians, gastroenterologists, and geriatricians. In my experience, definitely I do a lot of medical teaching with our house staff as well as physician assistants. And many of them who are newer and more recent graduates still think that PEGs should be offered. So we need to provide the education that we don't want to offer PEG tubes for advanced dementia patients like that. Another study looked at healthcare professionals and found that actually 82% of them would not want to be kept alive if they were in a vegetative state with a feeding tube. And then if they were minimally conscious, then 28% wouldn't want that. So we want to continue to provide ongoing education on these topics. Here's a resource that I found very useful. It's from the Monroe County Medical Society, mcms.org, and it really outlines the benefits and burdens of tube feedings in adults, looking across at a number of diagnoses, and then on the rows, whether tube feedings prolongs life or improves quality of life or functional status, or enables the path to curative treatments. As you can see, generally no, except in patients who have dysphagic strokes who at baseline had good quality of life and functional status, potentially can prolong life, as well as dysphagic patients, even if they have more comorbidities and poor functional status, at least in the short term, and then in ALS and vegetative states, if other organs are not affected. But for patients who have frailty, advanced dementia, advanced cancer, advanced organ failures, feeding tubes do not prolong life, nor do they improve quality of life or provide a path to cure. So I find that great to be very useful and can be shared with our colleagues as well as patients and family members. And here's a little bit more information. I'm not going to go through all of it. These are comparing the benefits and burdens of PEG placement over feeding. And then this one is the benefits of feeding orally and the burdens compared to rather than inserting the PEG. So these handouts will be available. So what can we do integrating all of this? these are some of the strategies that we can use to support nutrition and hydration in advanced dementia. Really, number one, find out the patient's preferences and advanced directives as soon as possible. As soon as someone gets a dementia diagnosis, we should be speaking with them about advanced directives and preferences for feeding down the line. To start using maybe nutritional guidelines, such as the one from South Australia, to provide higher caloric intake, enriched food with eggs and proteins, in a nice environment, adapt the food to the patient's needs, getting help from speech pathology as well as nutrition and dietitians, using assisted techniques, like maintaining visual contact, providing physical support, verbal cues, music, small amounts of feeds, involving familiar faces, allowing family members to visit if the patient is in an institution, and definitely using our interdisciplinary teams. The North Carolina group also did a study on the impact of a decision aid, which is a video on surrogate decision makers' perceptions on feeding options for patients with dementia, which is a very good video that can be used for public education and helping surrogate decision makers make decisions about feeding tubes versus comfort feeding. I'm going to pass it to Dr. Kupi to talk about an innovative project.
Okay, thank you, Cynthia. So I want to share a preliminary report of a performance improvement project we conducted at our institution, palliative care consultation prior to PEG placement. It's a policy approach to align medical decisions and goals of care through palliative intervention. Okay, so I share this because it's a novel approach, okay, but also I think that palliative care PC consultation is probably underutilized to get most institutions for this purpose. It may serve as a guide for your own performance improvement efforts at your institution, and it may also add some additional insights to the dynamic environment around consideration of PEG placement. The fact that it actually involves many providers, okay, we all want to make sure, okay, they're all on the same page and we're sending the same message. So by way of background, the scan literature on the frequency of palliative care consultation prior to PEG, our team observed that many dementia patients were undergoing PEG without a documented goals of care consultation prior to palliative care PC consultation. So a PI project was initiated on that basis. Again, speaking of proceduralists, again, we found that they expressed moral injury at doing these procedures, but felt it was not their role to do goals of care consultations or have shared decision-making conversation with family. Key stakeholders, okay, when we rolled this out was GI, interventional radiology, hospitals, voluntary doctors, our speech and language pathology people, so SLP, and of course the PC consultation service. Okay, we also agreed that a policy was required to ensure that palliative care consults took place prior to offering the scheduling PEG. The policy was not limited to dementia, since dementia is frequently not evaluated, not documented in the chart. It also, as pointed out by Dr. Pan, swallowing issues or feeding issues are really common at the end of life, regardless of the underlying condition. PEG replacements were included in our policy just to ensure the device is still aligned with goals of care, when PEG replacement was being considered. And in the end, we brought this to our medical board, who approved the policy, and it went into effect in July 1st of 2019. And I can say most of our prime physicians have embraced it, and one actually remarked that it should be a law. Next. Okay, so the study was designed and implemented, IRB approved, determining outcomes of PEG policy. We subsequently looked at primary PEG insertions for inpatients 3 years before and 3 years post policy. We found the procedures themselves, the codes used, did not distinguish between primary versus secondary PEG. So we did a chart review that showed that primary PEG place was typically preceded by an SLP evaluation, except for tracheostomy ventilator-dependent patients that would necessarily need a PEG anyway. SLP evaluation, note, prior to PEG was used as a surrogate marker for primary PEG placement. The measures we looked at for outcome measures were primary PEG placement, the number of them, the policy adherence, whether or not a PC consult actually took place prior to PEG, age, whether the patient resided in a nursing home, the presence of an ICD code for diagnosis of dementia, cancer, stroke. We're trying to see if there was subpopulation that we might want to consider, what the findings might show us. We looked at the average length of stay for admit to SLP evaluation, the length of stay for admit to PC consult, and also the length of stay from primary care consult, palliative care consult to PEG placement. The exclusion criteria, Conclusion was primary peg place, exclusion of procedures not preceded by the SLP note. Peg insertion done as an outpatient or not admitted in the ED were not included. Okay, we didn't include those that were done in the OR, because those were actually very rarely done in our institution. Okay, and just to note, primary peg place is not done as an outpatient basis at our institution, at our hospital. Our findings, were very revealing. There was a 22% reduction in primary peg placement, 20% reduction, among nursing home residents. There was good policy adherence. 94% had a PC consult. Pre-policy, only 31%, a third, had a PC consult. The median age actually decreased from 82 to 76 years of age. So we're capturing a wider population of patients through this policy. And the admit to SLP evaluation time is unchanged at 3 days, which seems about right. What concerned us, and what we have here, in red, is the average time for admit to PC consult was unchanged at 12 days. We think that's a very long time from admission. Similarly, the PC consult, the PEG, was unchanged at 5 days, and we were not able to do analysis of underlying conditions for dementia, cancer, and stroke, because we found that these are generally very poorly documented. They're not classified by type of stage. The ICD codes, even when they're present, they often lack sufficient specificity. So the next steps, we actually reviewed the policy, revised it in February 2024. For patients with advanced dementia, policy now states that PC consult should be requested concurrently with SLP consultation. In advanced dementia, SLP evaluation should be framed around determining aspirational risk of what types and types of foods can best be offered with the recommendation of confident feeding. SLP evaluation should never be framed around pass-fail, and we often hear those words, unfortunately. It should be better understood to be determinant of risk, but not determining the need for PEG. For patients with end of life, we should be proactively requesting PC consultation prior to placement of temporary feeding tubes. In these cases, we find that an AG tube is a bridge to nowhere, and often it's very difficult in having conversations with families. It's more difficult withdrawing something than starting something, especially when there's no benefit. And the CDI team, our clinical documentation experts here, are educating our staff on how to improve the clinical documentation, ICD coding. A future PI study will look at the impact of our revised policy and the education around it. So I'm going to hand this over to Kathleen Adinolfi.
Thank you. Thank you. So as Dr. Krupe mentioned, we saw the opportunities for improvement that would really require the collaboration of palliative care and speech-language pathology. What was happening initially was that there would be a speech-language pathology evaluation of swallow function, and the end result would be a recommendation for NPO and a goals of care discussion with the medical team. The caregivers would choose to wait and see. A nasogastric tube would be placed. There wouldn't be any improvement, and the caregivers would opt for a PEG placement. Then palliative consults would happen days later, and complex medical decision-making would be delayed. Length of stay was prolonged, potentially reducing the quality of life at end of life with the hospital stay and G-tube placement, which would be uncomfortable. So now our current goal is palliative care consult concurrently with the speech-language pathology consult, allowing for early complex goals of care discussions with the caregivers. And this is really going to support speech-language pathology's care planning. So a dysphagia treatment plan that aligns with goals of care can be established now. If the goal is comfort, SLP can focus on interventions that provide relief of dysphagia symptoms and reduce stress at mealtime. If more time is needed to establish goals, then we can provide ongoing swallowing assessment for additional information, or we can plan for earlier instrumental swallow testing if needed. There should really be a focus on chart review, looking at the diagnosis and prognosis and how that relates to swallowing function. Have the goals of care been established, or is goal setting still in progress? Has there been a palliative care consult? And if not, let's ask for one. And so when looking at the swallow function, we look at swallow safety and we look at swallowing efficiency. In looking at swallowing safety, is there risk for aspiration, malnutrition, dehydration, or aspiration-related pulmonary complications? And when looking at swallowing efficiency, does swallow function allow for sufficient oral intake of food and liquid? And so when the shared goal is for patient comfort, the goals no longer include eliminating aspiration risk or not even necessarily reducing aspiration risk. The goals become, how can we provide food and drink in a way that relieves distressing symptoms of dysphagia, such as coughing? How can we provide pleasant eating and drinking experiences and decrease patient and caregiver stress surrounding feeding? A well-known barrier to providing a seamless patient experience is that patients and caregivers often feel they receive conflicting information from multiple providers. So that's why it's increasingly more important to align our discussions and our documentation. I always recommend that the speech language pathologists avoid checkoff recommendations, NPO with tube feeds, goals of care discussion, because these complex cases benefit from a more in-depth SLP description of the diagnosis and its impact on the oral intake and swallow function, the prognosis as it relates to the dysphagia, evidence-based standards and guidelines, such as the Choosing Wisely guidelines for advanced dementia and how that relates to the swallowing function, goals of care surrounding nutrition and hydration management, if they've been established. And if they're not yet established, sort of laying out the options. So if it is going to be comfort care, here's what we want to provide. And if there is going to be ongoing assessment, here are some other options. So I also want to highlight that eating and drinking is a dynamic process involving multiple factors for consideration in the decision-making process. So including mental status, swallow physiology, swallow efficiency, and provider documentation should really avoid the language of failure. So they failed the swallowing test, can't swallow, awaiting SLP documentation to see if they can eat. And because a lot of confusion ensues at that point, because then the family says, well, it just left their mouth. They swallowed. Well, you're saying they can't swallow. It's rarely a yes or a no answer. And just again, highlighting that eating and drinking is a dynamic process that really benefits from more of an explanation of what we're seeing rather than a pass-fail. Okay, and so then we're going to talk a little bit about if comfort feeding is the goal, what does that look like? And so we're going to educate the families and caregivers about different practices for feeding in comfort. So upright positioning, awake and alert, small amounts, one spoonful at a time, be mindful of the mealtime environment, and providing nutrient-rich, dense foods. We're going to encourage physical activity to improve appetite, and getting out of chair. We might want to consult physical therapy or occupational therapy. And if the patient can't eat or it is uncomfortable at that point, finding alternative ways to show that love. And that might be hand massage, music, life review, referring to spiritual care or chaplains. Or it might just be taste of food. It might just be a lick of a lollipop of some of their favorite flavors, finding a root beer flavored lollipop if they loved root beer. So the collaboration between our speech language pathologists and palliative care teams can serve as a model for interdisciplinary teamwork that had a positive impact on patient care. So we accomplished that here through interdisciplinary huddles, case reviews. We had small group discussions about our documentation and how we can better align. We have case-specific communication, always reaching out to each other because every case is different. We also established shared patient lists. So if speech feeds that palliative has not been consulted in advanced dementia, we can sort of pass that on over, and providing joint education to our medical staff. So Dr. Pan, I'll pass it back over to you.
Okay, so thank you, Kathleen. That was fantastic. Just to wrap this up in a way of conclusions. Okay, there's so much we discussed here today. But I would start by saying feeding issues are common end of life, and present themselves as anorexia, cachexia, dysphagia. The guidelines are clearest for advanced dementia, with recommendation of common feeding and not to start feeding tubes, neither percutaneous nor nasogastric. Appetite stimulants are not demonstrated to improve long-term survival and may cause serious adverse effects. Palliative consultation is likely underutilized in most institutions for shared decision-making, and discussion of feeding options. Our policy-driven approach requiring palliative care consultation prior to PEG is an effective means to ensure shared decision-making around feeding issues at end of life. So we encourage other institutions to consider adopting that policy as their own. And we collaborate with speech and language pathology here in the ways that Kathleen described, like to identify patients with dysphagia and end-of-life diagnoses, partner in providing clinician and patient family education and appropriate documentation. Again, we all need to provide more public education to patients and families. I think that's something that's not been given sufficient emphasis.
And that concludes our talk. Here's a list of our emails. Feel free to contact us if you want to chat more or have specific questions. I want to say a huge thanks to Dr. Robert Krupe and to Kathleen Adinolfi, our speech language pathology colleague. Thank you.